Opening hospitals, creating more and more beds in any hospital in any country is never going to solve the problem of the ills of health for any country. The prevention, and primary care. You have to be able to treat people for diseases which are not hospital related at the doorstep. So the gold standard institution in Pakistan, I'm not going to name that, you obviously will figure it out, and the viewers also. More than 90% of their graduates have already left Pakistan for the United States before even graduating. So what's left is simply not able to deal with the load of it. We are doing very successfully through telemedicine, and we are reaching out to so many areas in Pakistan. Because one of the slogans of the Indus Hospital, which is now, by the way, the largest ever health network in the history of this country in the private sector. 500,000 patients are seen every month without charging of a single rupee.
Hello everyone, welcome to yet another episode of All Things Money, and during the month of Ramazan we're going to focus on how a lot of non-profit or charitable or social institutions work. And to kick that off, we've got Mr. Mashood, who's an executive director at Indus Hospitals. How are you doing, sir?
I'm very well, and thank you for having me.
Well, firstly, I would like to appreciate the wonderful work that Indus Hospital does, and I would say it's actually a global case study in how it's able to manage everything and just continue treating thousands of patients on a daily basis without charging a single rupee. How does that work?
Well, thank you once again, and thank you for your generous analysis of the Indus Hospital. So we got created 18 years ago, but the dream of the Indus Hospital, as our founding president, Dr. Abdul Bari Khan, puts it, was seen much earlier than that. It actually traces back to exactly 14th of July 1987, which was a very tragic day for the city of Karachi. And those who remember, there were two car detonation bombing went off in Bohri Bazaar, and the very young Dr. Bari then realized two things. One, that the then cosmopolitan of the country, Karachi, really didn't have a very strong emergency response. But he also realized that there were people standing with money bags and medicines and water and food, trying to offer whatever that they could to the civil society leaders. So he realized that there was this innate element of generosity that there was in the people of Karachi and Pakistan, which is both religiously triggered as an obligation, as you know, that as Muslims we have to be able to pay 2.5% of our Zakat, along with, if we go an extra mile, Zakat plus Sadaqat and charity and so on and so forth. So then he created a sense of movement, and Indus was established as the first ever cashless, paperless, there's no cash counter still at the Indus Hospital. And people of Karachi and people of Pakistan resonated with that idea of creating a hospital which will have no sense of discrimination when it comes to the social or religious belonging, and it will not be charging a single penny. It wasn't easy, Ammar, to be honest, because more than 90%, Dr. Bari says 99.9% of the people thought that even if we will be able to build this hospital, we will never be able to run this hospital. 18 years on today, there has never been a case when a patient is turned back from the Indus Hospital for not having enough financial resources. You asked how it works. It has worked because Pakistan is amongst the most philanthropic nation in the world. It is, some say it's in the top 5, some say it's in the top 10. Having said that, there is a very sizable amount of resources are given by the people of Pakistan in Pakistan, as well as the diaspora of Pakistan in the US, in the UK, and the rest of the world, which is directed towards the social causes in Pakistan and the rest of the world. An estimate of that is that now we have some clear regulations also kicking in. So there is a wonderful institution by the name of Pakistan Center for Philanthropy. It estimates that Pakistanis give in Pakistan between 300 to 900 billion rupees in charity, which obviously now goes, number one is immediate relief, and health is at number 6, which used to be the case not so long ago. It was number 3 in terms of analysis. So that is our number one reliance. Then over the period of time, the public sector in public service delivery has continued to how should I put it, continue to be not of the capacity that it can provide to the entire population. So under the umbrella of the framework of public-private partnership, a lot of public financing and public infrastructure is also available for institutions like Indus to tap into. So the government of Sindh, under public-private partnership, provides for 8 billion from this year, every year annual expenditure. That's their contribution, which amounts to around 25% of our overall expenditure. Then international diaspora of Pakistan. So Indus is amongst the top charities that gets benefited from the international Pakistani diaspora giving in excess of $30 million. So, but there are the likes of Citizens Foundation and Shaukat Khanam and other organizations also featuring in that. So that is how it operates. And that is precisely how it sustains itself, that every year where there are more and more challenges on account of either environmental or climate change challenges, because Pakistan is very vulnerable. Karachi just witnessed one of the greatest catastrophes in the life of the city, Gul Plaza incident, unfortunately. But once again, you would have seen that a lot of goodwill is geared towards the rehabilitation and the support to the businesses as well as the families who have suffered the loss of life or loss of business. So there is this wealth that is religiously embedded as well as socially channeled into these causes, which Indus and the likes of Indus continue to tap into and continue to sustain their operation.
All right, wonderful, because I think it's one of the few hospitals in the country, very few, which does not have a cash counter.
Yeah.
And because of that, there is no discrimination. I mean, I personally know a lot of people, personally been there. A lot of institutions, Karachi essentially, there's no cash counter and there is no discrimination in terms of showing up your ID and just checking where you're from. So do you think what needs to be done to really scale this model up? I mean, charitable donations, they can only go to a certain extent. How can public-private partnerships be scaled up where the operational excellence that Indus has demonstrated can be tied up with significant quantum of health expenditure which already exists in the public sphere, and we can get much better institutions out there, not just in Karachi, but across the country?
That's a remarkably insightful question, which has many layers to it. So when it comes to the public funding, not the government funding. So let's just try and delineate by using two terminologies. People funding, you want to say, or public funding, you want to say, and then let's just call the government funding, which is also
public funding,
the taxpayers' money.
That's
right?
correct.
So when it comes to the effort of the Indus Hospital and how we want to move forward, so it has to have a two-pronged approach. Mm-hmm. One kind of funding is called the consumptive model, which is for immediate needs. And many needs in healthcare are very immediate needs, right? But Indus became an institution not because of the consumptive model, but what you call the transformatory model of funding, whereby there are donor organizations or individual donors or businesses which are institutionalizing their donations for a long-term investment in the public sphere for public services to get better.
Yeah.
So some of our big donors are infrastructural donors, and they want to continue to give support to the Indus Hospital for capital expenditures rather than for operational expenditures. And why do I want to do that? Because they say that we want to build Indus into an institution which is going to last for many generations. And that is why there are certain donors which are only available for creation of endowments or for business models which are not going to be on the course of collision with our overarching value system, which is that we will not charge the patients. Whoever walks into the doors of Indus Hospital will always be treated free, as you said, without any discrimination. The government becomes complicated because the government in the end cannot fully outsource two things. One is education and then health, because constitutionally these are responsibilities of the government. But over the years, since we have seen the very gradual erosion of the public sector in terms of the human capital, in terms of their overall ability to provide high quality, as you used the beautiful word excellence, for both education or health, or for that matter water and sanitation and all the markers of overall human development index, they were either forced to or they were proactive enough to come up with frameworks which enable and allow institutions like Indus to enter into public-private partnership modus operandi. The scalability of it continues to be a very big challenge, if not a question mark, because the frameworks continue to suffer significant amount of red tapeism and bureaucracy, which obviously any government is known for. So the fluency of, or the fluidity of financing and the availability of the framework in terms of procurement policies, in terms of implementation frameworks and policies, are not necessarily very user-friendly for a lot of institutions to believe in the fact that there can be a symbiotic and a very long-term transformatory partnership with the government. Then political upheavals, Ammar. One government comes in and they believe more in working with the not-for-profit or private sector. The other government comes in and they don't believe in that. We have suffered on that account because we were running a lot of hospitals in terms of public-private partnership, and then the political climate changed, and then the government wanted to run those hospitals on their own, whereby we had set the capacity and the excellence and the quality of those hospitals to a benchmark where we knew, and the government also knew, that they will not be able to sustain those benchmarks. But nevertheless, they were their hospitals, they had to be given back, and then they were turning back to Indus to take them again. So it's a complicated situation, but the way forward very clearly is that if somehow the private institutions or the not-for-profit institutions are able to build the capacity at the local level, only then the scalability question mark of the human capital gets addressed, and only then the scalability is possible. In health sector, I can tell you that one of the greatest challenges is the provision of high quality human capital. As soon as you leave Karachi or say our urban centers, the human capital takes a nosedive. You can't find good doctors. If you're lucky, you can find a doctor. Then you can't find paramedics. The whole paraphernalia of healthcare is much more complicated than that of education now, Amar, because there are not-for-profit organizations running very good schools, but to run a school and to be able to run a primary care clinic, there is no comparison. It's apple versus oranges, because you have human lives at risk when you are dealing with healthcare. Yes, there is human dignity and social capital at risk when you are talking about education, but it is not even a comparison. When people draw those comparisons for me that, XYZ is able to run their schools in the rural areas, why are you not able to run primary care centers in the rural areas? I look at them and with a smile, frankly, because you have to be able to deploy responsible primary care physicians, public health experts, and with them the necessary technical support staff for you to be able to do justice to a semblance of quality which must be given to the people of Pakistan. Disaster relief work, we all saw what was happening in COVID. Everybody and anybody was wanting to get into the healthcare. Many were actually demanding cash on the table before they will allow people to enter into the hospitals. People had created ventilator rooms, ICUs, without having the necessary technical expertise. Ventilator is a very, very life-threatening thing, but they were getting away with it because there is so much of dearth of these things. So the scalability question, the jury is out on that, Amar. It's a very pertinent question. We believe that if continued investment is made on the human capital front in the rural centers of Pakistan, and if technology is deployed, which we are doing very successfully through telemedicine, and we are reaching out to so many areas in Pakistan, because one of the slogans of the Indus Hospital, which is now, by the way, the largest ever health network in the history of this country in the private sector. 500,000 patients are seen every month without charging of a single rupee across the network. And a lot of our primary care centers, which are 134 in total across the country, we are now deploying telemedicine. But telemedicine not as a flamboyant, extravagant term. We want to close the loop in terms of the diagnostic and the provision of medicines to support that diagnostic. Why I say that? Because if you come to me and I diagnose you for diabetes, and I know that you don't have the financial means to buy the medicine of diabetes, I know for a fact that you will come back with a much higher burden of disease, which can be amputation, which can be multi-organ failure, which can be implication of your kidneys and whatnot. Why shouldn't I give you the necessary medicine also, so that you are actually treated for that? But the unfortunate part of that also, Amar, as you peel the layers of the onion, this is where health becomes more and more heartbreaking and more challenging. We know for a fact that at times we have given medicines to our patients, but the level of poverty at times is such that they were forced to sell those medicines in order to feed their children. So it's a very complicated situation. The scalability is not for hospitals, it's for using of the technology and spreading what the term is universal health care at the doorstep of the people of Pakistan, so that we can arrest the burden of disease at the doorstep of the people of Pakistan.
I think this is excellent. This is exactly what I was segueing towards. So what I can understand here from our conversation is that operational excellence is essentially constrained by human capital.
Yeah.
So it's not about you can have enough infrastructure, but if there are no people working in it, that infrastructure is completely useless. So the biggest constraint or the critical path here goes through having the right quality of human resource.
Yeah.
And then we can always talk about controlling the burden of disease, essentially what can be done for preventive maintenance, what can be done at a primary health care clinic such that the burden does not shift to a bigger hospital, so on and so forth. Indus over the last 18 years, as you said, has done a lot of work in that, in terms of developing that capacity, in terms of understanding how a primary healthcare unit can work, how a big hospital can work. In terms of what needs to be done, from what I can see, there is enough money sloshing around. I would use this term very liberally because, as you said, there is private capital, there is donor capital, there is government capital, which just wants to do something, but as you said, the people aren't there. So that is the constraining criteria. What do you think needs to be done from Indus's experience to really develop that kind of capacity at, let's say, at a very specific district level or tehsil level, or how can we have a more representative development of human capital across various areas?
You see, there's no magic bullet to it, other than the fact that we have to be able to provide sustainable employability and skills for employability in those areas. We have to be able to break the mindset of the young people rushing towards the big cities of Pakistan. Not very many people know, but Karachi is the fastest growing city in the world, and that too for a very long time.
And the census does not say any of that at all. Actually, it says that the population is declining.
I don't know where is it declining and how is it declining, but 40% increase, average increase every year at the Indus Hospital for patient load.
Wow.
40%. You see, one of the greatest complaints against the Indus Hospital is that of the fact that
There's a wait time.
कि वेट टाइम और बेड नहीं मिलता है. अब किसी को बेड से गिरा के दूसरा बंदा तो नहीं बेड पे लेटाएंगे. That is why we're expanding and we're building Pakistan's history's largest infrastructure in the private sector, 1,350 beds, which is 3 times the size of the largest private sector hospital that there has been in Karachi. But you see, we have to be able to learn from countries who were able to inculcate a very strong sense of patriotism or social responsibility of their human capital, which was not obsessed with 2 things: A, urbanization, and B, only working for financial gains. So that's where I think, unfortunately, it's a bit of a philosophical response that I have, which I will then convert into an operational one also, that the more polarized as a society we have continued to become, the more discompassionate we have also become as people towards our own citizens and their own needs. So the gold standard institution in Pakistan, I'm not going to name that, you obviously will figure it out, and the viewers also, more than 90% of their graduates have already left Pakistan for the United States before even graduating. So what's left is simply not able to deal with the load of it, and the migration of that, you can very well imagine, leaves a very big void in terms of the skill set, which in the end is required for us to be able to roll that out. Not all of them, the 90% leaving, are from Karachi. Many of them were able to break through the system, and they came from rural areas and they made a mark for themselves, but they never went back home to serve their own people. The infrastructure, very rightly pointed out by you, needs to resurrect itself. There's a graveyard of infrastructure in terms of basic health units and primary care setups and brick and mortar, where deployment of initially these people on a short-term basis, such as outreach programs which are run, that institutions, Indus is building one of the largest health sciences universities, inshallah, in the future, with 7 different schools. And what we are trying to build into the curriculum is an outreach program, that those wherever they come from to become doctors or dentists or paramedics or medical technologists, they will be required to serve 3 months of every year during the course of their education in the areas that they came from, or necessarily in the rural areas, so that they are able to build an opinion and a perception that those areas are also livable. The government has to come hand in hand, in terms of uplifting the road infrastructure, the electricity, the water and sanitation, and above all, housing, so that people like me and you, if I won't name you, but if somebody were to ask me to go and serve in a remote area, and I won't also do that. So why should I be expecting the same from somebody else who is perhaps more accomplished than me to be able to give that service? So those facilities, private sector has proven, for-profit private sector. You, as a very learned host of this program, would know that many settlements of oil and gas companies do attract very qualified young people to live out of very remote areas in interior Sindh or say interior of Pakistan. How come? Because they do then supplement the same with those kind of facilities where those young people can actually continue to have a quality of life. So it's a full package. Otherwise, we will just continue to see, which is a cliche term, the brain drain, or people not really positioning themselves to serve the country in the healthcare sector across the country.
I think this makes absolute sense that even money may not be enough to attract someone to work in a certain area when the necessary ancillary infrastructure is not there.
Absolutely.
And that requires an overall upliftment rather than just looking at pockets on its own.
Yeah.
That just makes total sense. So coming to how operations are run of such an entity where there is zero cash, zero counter. Normally in socialized healthcare globally, let's say if you look at Canada, if you look at the European Union, we see that there is the efficiency suffers in terms of how far can taxpayer money can go. The incentive alignment is out. How do you ensure that the incentive alignment is not distorted? Let's say there is no wastage, because when let's say if it's pure shareholder oriented or it's a government oriented, you're looking at how to make things more efficient. What incentive do you have? What incentive such an institution has to make things more efficient and to ensure there is no wastage?
See, another wonderful question actually. I'm not medically trained as a person. So my training is business management and strategy development. But the 7 years that I've spent at the Indus Hospital, I've realized that building a hospital and running it with world-class standards is the hardest thing one can do, frankly speaking. Also, locally and internationally, Amar, I must tell you that the policy framework, the quality assurance framework, all those standards are available now with the influx of social media as well as other global platforms. They are accessible. You just have to be able to pursue those as a serious institution, and you can acquire those with a lot of hard work, a lot of dedication, and above all, very brutal accountability. We are very proud to say that our blood center, Indus's blood center, is the only blood center in the entire SAARC region to have American Association of Blood Banking certification. No other blood center in the entire region, including India, they have been able to acquire that accreditation. Why? Because we planned accordingly, we deployed the leadership accordingly, we followed the processes accordingly, we implemented the policies accordingly. So there is no shortcut to having excellence in your operations. You have to be very vigilant, you have to be highly policy oriented, and you have to have the necessary layers of accountability. The dashboards are possible now. So our president, to our CEO, to our medical director, to all the faculty heads and so on and so forth have cutting edge access to technology where they are able to see their dashboards of performances. The KPIs are set in their operational plans, in their targets. Our board of directors is very hands-on when it comes to ensuring two things: that public funds, which are coming through government financing, religious funds, which are perhaps far more delicate in terms of their sensitivity, because people are trusting Indus with their religious obligation as a vakil for us to be able to utilize those funds. All those, along with the quality standards of care that we have promised to the people of Karachi, particularly the people of Pakistan, the underserved people of Pakistan, has to be up the mark, and the KPIs of that particular process are monitored on a daily basis, on a weekly basis. It's very extensive. Technology plays a pivotal role on that front. Today also, as you know, that everybody has a mobile phone. We are also on our toes. There are significant also violations on the use of those mobile phones also, because patients are coming and they're filming their own people, and then at times it becomes a scandalous act. At times it actually opens our eyes also in terms of staying far more vigilant and in terms of executing and rolling out our health services. So again, it's a long answer. Why? Because the institutional layers of accountability have to comply with the policy framework of the health standards given to every hospital by the Health Commission in Pakistan. They have to be taken seriously. Indus takes them very seriously. Even if the government is not taking them seriously, we take them very seriously. Then the international standards, because our hospital has been designed on the standards of Singapore, which is known for the best possible health infrastructure and service delivery. There was a team very recently from the US by the name of, led by Dr. Umar Birni. The team is called GODA, which is the Gift of Disability Alleviation. They got $6 million worth of equipment, as well as a lot of American doctors. 26 people came and carried out more than 300 knee replacement surgeries, totally free of cost. In their words, I'm proud to say that they have never operated in the kind of quality of operation theater suites that in the new hospital building of Indus has. It's the largest assembly of operation theaters that there is in the country, in both in public and private sector. 29 plus operation theaters integrated with AI, with global integration. I request you to come and see them for yourselves, because seeing is believing. Plus specialized another seven operation theaters, which are for even greater complicated surgeries, ranging from, inshallah, in 3 years' time, neurology to transplants and so on and so forth. So it's a perpetual effort of pursuing excellence by deploying international and local standards. For financial transparency, we are audited by the Big Four, we are audited by international organizations, we are audited by all the necessary Islamic Sharia bodies also, and we are very open towards our financial transparency also. We actually welcome it so that we can learn and we can give greater service.
I think this is excellent. So let's just look at some numbers here. What would be there are like 29 operation theaters.
Plus
what
6.
would be the utilization? How many operations would you be doing on a daily basis?
If you're talking about smaller surgeries, we are in excess of 2 dozens every day. But that's where it is back-breaking for the poor people, Ammar. Because one surgery can really take away the entire income for many years of a small household. So there are dozens every day which are happening. And then I give you an example anonymously. There's this boy who was diagnosed with cancer in the hand, and we have the privilege of having one of the 2 doctors in the country, in the entire country, who specializes in saving the limbs from the cancer as well as the treatment, and under any circumstances the limb has to be saved, and he specializes in that because he carried out 8 surgeries. He's an 11-year-old boy, 8 surgeries. In the market, those surgeries would have been worth more than 15 million rupees with rehabilitation. But the boy's hand was saved, and he's living a full life. I give you another example of, we are the leading cochlear implant organization in the country, which is a magical device, because many children who are born deaf, they also don't speak because they don't hear anything. So this is an implant, a device. The earlier the better. It gets installed with speech therapy. In 3 years' time, the child can hear, the child can speak, and leads a completely normal life. That implant in the private sector can cost you a fortune. Minimum 4.5 million rupees with the surgery and the device and the rehabilitation and the speech therapy. We have crossed 300 of them, absolutely totally free of cost. And another team, is, as we speak, will be landing in Pakistan to carry out more than 100 head and neck surgeries of very critically ill children and women and elderlies. The team is coming from the States, and they will also be giving that service through us. So we have become that institution now, mashallah, which is the largest in the public service delivery of primary health care, the largest provision of safe blood. You know, more than 80% of the blood being given to the people of Pakistan is not safe for human consumption. It's an explosive situation for hepatitis, for HIV and whatnot. We are the largest provider of safe blood in Pakistan. We are the largest provider of rehabilitation. These are lifelong patients. We have 3 rehabilitation centers across the country where we make the limbs ourselves and we deploy them, we rehabilitate them. We are the largest childhood oncology center in the country. More than 2,400 children are treated totally, absolutely free of cost, and we have the highest conversion of, alhamdulillah, towards complete cancer recession in childhood cancer in Pakistan also. So all of it is going on, alhamdulillah.
And just phenomenal work. I mean, words can explain. So in terms of pure numbers, how many patients are we treating daily? And what is the nature of the work being done? It's a lot of OPD, is a lot of, like, what's the breakup like?
So you see, when it comes to the hospital, we have more than 2,000 patients coming in our emergency every day. And 30 to 40% of that, they do require a bed. Obviously, we don't have that many beds. That is why we're continuing to build capacity. We will be a 100-bed emergency in the next couple of years, with 50 beds dedicated to pediatric, 50 beds to adult, which will be the largest in the country as an emergency.
And if I may ask, in terms of emergency, let's say 40% of 2,000, roughly 800 people are coming and they need a bed. What is the nature of the disease that needs to be?
You see, respiratory, accidents, changing climate. Karachi also, unfortunately, had an element of smog this year, which was known for Lahore, but Islamabad also got hit. Heart, diabetes. Pakistan is #1 carrier of burden of disease of diabetes in the world.
So most of these.
But 50% of the people who are coming to the Indus Hospital every day should not be there.
Exactly, that's what my point is.
50%.
How to reduce that, what prevention can be done to actually reduce that, because you can add unlimited number of beds, and if you don't really control the source.
I tell you now, you have answered, you have basically answered your own question very, very beautifully. Opening hospitals, creating more and more beds in any hospital in any country is never going to solve the problem of the ills of health for any country. The prevention, 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 and primary care. You have to be able to treat people for diseases which are not hospital related at the doorstep. So what we have done is that we have integrated for the first time family medicine, which is nazla, zukam, khansi, bukhar, and other illnesses in the hospital. We have 3-4 clinics on a fast track where immediately, because the patient coming into the emergency has the mindset that it's make or break for him or her. खाली नज़ले में बेचारा ऐसे हुआ होता है कि जैसे उसे कार्डियक अरेस्ट हो गया उसको, उसे यार भाई कुछ नहीं हुआ तुम्हें, लेकिन उसको he's come all the way. The satisfaction is that he has to be seen by a doctor, and that's where the 3-4 hour wait kicks in.
Okay.
And that's where the reputation is that you come to Indus, you have to spoil the whole day. They will stay 3-4 hours, pay through their nose in other private hospital and won't say a word. Here, they are sat well, they are looked after, they are not charged a single penny, and the kind of racket that they throw is unimaginable. Having said that, coming to your point, they are fast-tracked and they are said, Khudafiz bhai, you don't need to be in a hospital, you don't come back for a follow-up even, you have seasonal flu. I'm just giving an example. So triage is done to separate the real problem from the problem which shouldn't be the problem coming to the hospital. But since there is no provision of the primary care at the doorstep of those people, they have to be able to come to Indus, because health is a double-edged sword. Either they have a very, very expensive private hospital to go to, or not so performing, or they don't trust the provision of the public health care facility. Because, you know, Pakistan is amongst the highest per capita injection nation.
Why?
Because इंजेक्शन लगा तो आराम आया,
तो फील अच्छी आती है
नहीं, जो गली मोहल्ले पे जो आपके ये बुचर्स बैठ गए, चाइल्ड स्पेशलिस्ट, तो दैट स्पेशलिस्ट, मार्केटिंग इज sarcastically speaking stunning, na? Simple people, they go to these clinics.
अगर इंजेक्शन लग रहा है तो सही हो रहा होगा, कुछ ना कुछ तो हो ही रहा होगा.
And many a times they are steroids.
Yeah.
Many a times they are expired drugs. Many a times the sterilization of the injection is highly questionable. Pakistan is amongst the highest, unfortunately, has become one amongst the highest nation in the world for antibiotic resistance.
Yeah.
Because self-prescription and instantly antibiotic is given by the gali mohalla doctors.
So you don't have to go there anymore. Do it yourself.
लेकिन क्या करें? Then the load is on Indus. Then the load is on the likes of Indus, who are trying to do a responsible act by telling people, by making people aware that, you know, don't take the medicine. The parental anxiety, the shortcut to cure, and the absolute impunity के साथ provision of steroids and chemo-based drugs for instant cure at the gali mohalle ke clinic. It's scary in this city and the country. Pakistan is amongst the highest in dental quacks.
Yeah, I think at this one they're only quacks.
No.
Like if you look at it, they're only quacks.
लेकिन यार oral cavity के अंदर hepatitis, HIV, जानवरों के दांत and what not. That is why when Indus Hospital becomes complete, it will have more than 100 dental pods. Because the disease burden
starts from
blood, water, and your oral cavity is more than 80% of your entire disease burden.
So you fix this, you fix a lot of other
Absolutely.
things.
We're trying to.
So I mean, I'm just taking a cue from them. I'm sure you definitely tried this. That 50% who are patients come, that's mostly can be sorted through a family care clinic. You would have a fair idea where those patients are coming from. There would be a cluster. I mean, if you look at the data, they have a data driven report, you would see a cluster of, you know, from this X area, I get like 5% of my patients.
True.
Y area, I get another 6% of my patients. What if we set up family care clinics by Indus Hospital doing the same thing at their doorstep, close to their doorstep, so that the burden on the main hospital reduces? Again, replicating the model of socialized healthcare elsewhere. Have you tried this? How does that work out?
I think you should quit this job and work for the Indus Hospital because exactly that is what the plan is. That in the next 3 years, we will have given coverage to entire Karachi through telemedicine and through the provision of primary health clinic. But we don't want to reinvent the wheel also. There are wonderful primary health facilities already operating. What we are trying to do is to strike partnerships so that economies of scale can be acquired, so that we are not wasting resources, be it given by the government or be it given by the people of Pakistan, be it a religious obligation. We want to strike partnership, and courtesy this, I would like to also highlight that we're very close in terms of striking certain partnerships, even with integrating primary health care, education, as well as our tertiary hub and spoke model facility. There comes a little bit of unfortunate challenge that at times we have realized, and I don't take a higher moral ground or sense of entitlement at all. So you or viewers shouldn't get me wrong at all, but I do say that with complete sincerity and clarity that we have tried to strike partnerships with a lot of organizations, but the territorialness, unfortunately, is pretty high in the not-for-profit sector.
Yeah.
At times, it is residing in the right area of the heart, where they do feel that they have the better skill set and organizational strength to offer, and we respect that. But at times, it is simply projection, or the risk to projection by thinking as if a bigger brand, for lack of a better analogy, will consume them rather than will partner with them. So it's not easy, which traces back to my comment of the polarization that we have seen in the past several decades in our society. At times is not allowing us to come under one umbrella, be it our flag, be it our identity, be it our social service, be it anything, for us to be able to work collectively for the benefit of the people.
Yeah, absolutely. And I think the only collectivism can actually come from the state, as you say, because the state will not be in competition with itself.
Yeah.
And frankly, I mean, if you ask me my view of non-profit, I fully agree with you, and that is why it's rare to find a non-profit that's actually doing things and scaling up, because a lot of the territorialness is mostly from the small or mid-sized ones, and that always becomes a problem. It's definitely distracting. So we'll just round this all up and end our fascinating. I wouldn't want to end this, but we're almost at an hour at this point. So in terms of numbers, where do we see, or in terms of strategy, for example, where do we see Indus in the next 5 years?
So we have a 15-year plan, not 5 years.
That's even better.
Because it's actually divided into 3 phases, 5, 5, 5. We have a very clear, which is on our website also. So we have 5 strategic directions, complemented by 3 pillars of the strategic direction that we wish to take. Number 1, we want to tap into international funding as well as government funding and infrastructure to spread universal health coverage across the country. Under that, our slogan is reaching the unreachable. So we, Amar, don't want to be in areas where there is a semblance and the provision of healthcare. We want to prioritize areas where there is none.
So just coming to the cutting you in between.
Sure.
Availability of healthcare does not imply availability of quality healthcare.
True.
So where do you draw that line?
It has to be it has to be of our comfort. So we either will uproot and go into competition with the existing, which we don't call healthcare. We want basically cashing in on the vulnerability of the people. And we have fought those battles with the mafias of these corner doctors and the mafias of these pharmacies and drugs and so on and so forth. And we continue to, we call it a jihad of its own kind, frankly speaking, that we have to be able to dismantle bad health practice for us to be able to give good health practice. So you're absolutely spot on that it has to check our boxes of baseline of provision of good health care. So we have a comprehensive survey on that account. That is why we qualify or disqualify an area for coming in and installing that particular facility, that it has to have that semblance of health care, which is well-meaning and of reasonable quality, or else we will come in. We want to, so coming back, so that's number one area, which is giving as much coverage to arrest the burden of disease at the doorstep by prevention and by primary care. We then want to, number two, hospitals. We don't want to build hospitals senselessly. It is a very, very costly thing. It can cost billions of rupees. We do want to have at least a 600-bed hospital in every provincial headquarter moving on in the next 15 years. The largest will always be Karachi, which is 1,350 beds, and will come to 1,800 beds if need be. The second largest, by the way, is in Lahore already. The building is complete, given by the people of Lahore. And the largest donation that Indus ever received, single donation of the time, did come from one of the founders in Lahore. So that is we want to convert them into world-class tertiary hospitals. We want to tap into public-private partnership for secondary care of government infrastructure. We have done that successfully, so we want to do that. That basically covers the primary and the hub and spoke model of comprehensive holistic healthcare. We have to do R&D. Pakistan must have its own pharmacy capacity, pharmaceutical capacity, as well as other. Number four, human capital development, from short courses to technical courses to graduate courses and all spectrums of health. We want to invest in the youth of Pakistan on that account, and global resource generation and partnership. So these are the areas. What is driving is the patient experience at the heart of it. So the patient-centric or people-centric organization we have to have by tapping into the religious obligation as well as government and grant money, inshallah.
I think this is wonderful, Mashood Saab. Thank you very much for your time. It's a fascinating discussion.
Thank you, sir.
All right, everyone. This is it for another episode of All Things Money. Until next time.